Hi, my name's Dr. Chris Sear. I'm a nephrologist and this is an educational video for Telecare. So today I wanted to talk about diabetic kidney disease and in particular the SGLT2 inhibitors. So it's been a long time since there have been any significant advances in diabetic kidney disease. In 2001, two studies were published in the New England Journal of Medicine regarding angiotensin receptor blockers, losartan and irbesartan. And in these studies, ARBs versus placebo were shown to reduce the primary kidney outcome of the doubling of the serum of the creatinine, end-stage kidney disease or death. And this was by about 15 to 20%. So this was the big breakthrough in diabetic kidney disease in the early 2000s. And unfortunately, there really hasn't been anything since 2001. It's not from a lack of trying, however. Various investigators have tried dual RAS blockade, bardoxolone, antifibrotic agents, various things, but all of them have failed. And now that's why it's really exciting that we have this new drug, or this new class of drugs called the SGLT2 inhibitors, which have shown some really promising results in trials. So SGLT2 inhibitors block sodium and glucose reabsorption in the proximal tubule, which you can see here. And what this results in is increased salt delivery to the macula densa, which makes the glomerulus think that it is receiving too much blood. This results in constriction of the afferent arteriole and reduction or throttling of the blood to the glomerulus. And acutely, this is going to decrease your glomerular filtration rate. But in the long term, it actually protects the glomerulus from glomerular hypertension, hyperfiltration, and probably is renoprotective in the long term. So there have been major trials which have been focused in the general population or the non-CKD population. And these were the DECLARE trial, the CANVAS trial, and the EMPA-REG outcome trial, which studied the SGLT2 inhibitors dapagliflozin, Canagliflozin, and empagliflozin. And so, as I said, these studies were performed in people with preserved kidney function with minimal proteinuria. So then they're really not the sort of patients that I, as a nephrologist, see. The renal outcome numbers, or the adverse renal outcome numbers, were very small in these very large studies. But let's have a quick look at them anyway. So in the EMPA-REG study, as an example, this drug, this SGLT2 inhibitor, actually reduced cardiovascular death and all-cause mortality by around 30 to 40%, which is a huge reduction. And it's interesting to note that the ARB studies did not demonstrate any cardiovascular protection, but their primary outcome was indeed looking at kidney function. And let's have a look at renal outcomes for these SGLT2 inhibitors. Again, good figures for renal protection. So this combined endpoint, the composite renal outcome of progression to macroalbuminuria, doubling of serum creatinine, renal death, or initiation of renal replacement therapy. This was also reduced by about 40%. And this was in patients who didn't have CKD. So the investigators asked themselves, what would happen if we used this drug in a patient population that did have CKD? And hence the credence trial was initiated. So this was a study of type 2 diabetics with down to stage 3B CKD, so eGFRs of 30 mils or more, and they had significant proteinuria. They were randomized to canagliflozin or placebo. It was a large trial, 4,000 patients, but it was stopped early because of efficacy. And you can see here the primary outcome, which is the combined outcome of end-stage kidney disease, doubling of the serum creatinine, or renal or cardiovascular death. You can see that this occurred much less frequently in the canagliflozin group rather than the placebo group, and the hazard ratio was 0.7. So there was a 30% reduction in this primary kidney outcome, which was highly statistically significant. And if you break it down, looks like everything is to the left of this line on the forest plot, suggesting that for all of these outcomes, canagliflozin is favored. In terms of renal adverse effects, interestingly, this favoured canagliflozin as well, which is not really something you'd expect, but there was definitely no safety issue with regards to renal safety in this trial. Now, what do we need to look out for? Well, there was an increase in mycotic infections, so genital mycotic infections, but interestingly not urinary tract infections overall. And there was a large increase in euglycemic diabetic ketoacidosis. So in summary, the credence trial showed that in a high renal risk patient group, canagliflozin was effective in reducing renal events. I haven't shown this data here, but there was also some small improvements in blood pressure, weight, albuminuria, and reduction in HbA1c. And we are seeing some safety signals. You've got to look out for DKA, you've got to look out for genital mycotic infections. So can we use these in Australia? Well, the PBS has some specific indications for SGLT2 inhibitors, namely, you've got to be on either metformin or sulfonylurea or insulin, and you have to have an HbA1c of more than 7%. Unfortunately, canagliflozin is not listed on the PBS, but we do have the option of empagliflozin or dapagliflozin. And empagliflozin can be used down to an eGFR of 45, and the product information recommends that you shouldn't use it if the eGFR drops less than 45. So can we extrapolate the data from credence, which is canagliflozin? Can we extrapolate that to empagliflozin and dapagliflozin, which is on our PBS? And I think the general feeling is that it probably is a class effect, but there are more trials that are in progress in this area. So EMPA-Kidney recruiting CKD patients for empagliflozin, and DAPA-CKD recruiting dapagliflozin CKD patients. You can see these trials will be very informative in the future to guide us as to whether we can expect a similar benefit with empagliflozin and dapagliflozin. So what's my take on all of this? Well, I think that SGLT2 inhibitors are the biggest things in diabetic kidney disease since ARBs, and they're probably even bigger than ARBs because of their cardiovascular benefits. They have proven benefit with regard to kidney outcomes in the general population, but also in the CKD population from credence. I am quite keen to use SGLT2 inhibitors in anyone that will qualify. So at this point in time, you've got to have a GFR more than 45. And I think that they have a place after metformin. Future trials are ongoing, which may change the eGFR cutoff, and I'm hopeful that in the future that number will drop a bit lower. It's important to tell people not to take the drug if they're sick or having surgery, and warn them about side effects such as mycotic infections, polyuria, and diabetic ketoacidosis. Well, that concludes our webinar today. I hope you enjoyed it. My name's Dr. Chris Sear for Telecare. See you next time.